Hello everybody and welcome to this ABC and Eurodrug webinar about COVID-19 and how Italy faced with the challenge. I'm Severino Previtali from ABC Farmaceutici Italy, and today we have invited Professor Pierachille Santuz to tell us about Italian experience in the treatment of COVID-19 patients. We are very happy for the large participation to our webinar and have attendees from Asia, Latin America, and Europe. Thank you all for connecting with us. I would like to shortly introduce our speaker, then I will pass the floor to Professor Pierachille Santuz for his presentation. Questions will be answered at the end. However, please feel free to send us any question you may have during the presentation. You can type and send them through the question and answer button at the bottom of your Zoom window. As many of you may know, Italy was considered ground zero for COVID-19 in Europe and heart of the pandemic. Sacco Hospital in Milan was one of the main health centers designated to treat COVID-19 in Italy, and it is therefore with pride that I introduce our speaker, who is the head of the respiratory department of the Luigi Sacco Hospital in Milan. He graduated in 1996 at the School of Medicine at Milan University and participated to the residence program in respiratory disease between 1996 and 2000. Professor Santuz obtained his PhD on molecular biology, curricula molecular oncology at the University of Milano during 2004. During his career, he did postdoctoral researches around the world. He works in a clinical setting, managing all the acute and chronic respiratory disease in terms of diagnosis and therapies, both non-invasive and invasive techniques. Professor Santuz has an excellent experience as principal investigator in national and international clinical trials in accordance to good clinical practice. In particular, he is principal investigator in clinical trials and international randomized clinical trials focused on COPD and asthma innovative treatment. He is member of the European Respiratory Society and of the Italian Respiratory Society. He is author of more than 100 peer-reviewed publications and co-author of several book chapters and monographs. Professor Santuz served as a reviewer for many respiratory journals as well. Fine, many thanks for your attention. Let's start the webinar. I give the floor to Professor Pierachille Santuz.
Hello. Hello, it's a pleasure to meet everybody, and it's a pleasure to be here. And unfortunately, Professor Santuz will be here in a few minutes. I will start, and I will present myself in a second. I will start the presentation, and he will continue very soon. Unfortunately, he was called to participate in a very important meeting regarding our department and our respiratory department in particular, and that will face let's say the new chapter of the COVID era here at the Sacco Hospital in Milan. I am Dr. Radovanovic Dejan. I'm working with Professor Santuz since 2005, and I had the pleasure to work with him in this difficult situation, and during this pandemic. I managed all the patients in the sub-intensive unit, in the intermediate care unit, in which we worked in the last 3 months. So I'm going to share with you the screen now and to start the presentation. Okay. So in the next 20-25 minutes, we will give an overview of what happened during the COVID pandemic here in Italy, and then especially what happened and how was managed here in Milan and in our region. So just to specifically, we were the coordinating center for the intermediate care units, respiratory intermediate care units in Lombardy. So in our case, we managed and took care of many complicated patients, at least very severe patients coming from other secondary care hospitals and emergency departments all over Lombardy. So what we knew at the beginning of the SARS-CoV-2 infection was related to the publications that were accepted and published in the major clinical journals, and especially in the New England Journal of Medicine, where in the first days of March, this important paper came out, and the New England published this observational study regarding more than 1,000 patients in the Wuhan region, that encompassed more than 500 hospitals and 30 provinces in the mainland China. And the main outcome of this observational trial was to assess which were the symptoms, the signs, and which were the outcomes of the patients treated in that period and during January 2020, and to assess which were the characteristics of the patients that were admitted to the ICU, underwent mechanical ventilation, or died during their hospitalization. This was kind of a composite outcome that the authors used. And this is a very busy table, but this is just to describe which was the population, which was kind of different from what we faced a month or two after. So as you see, the distribution of the age of the first columns is, of course, a little bit different in patients that were severe rather than not severe, and that had the composite outcome rather than survived or were not admitted to the ICU. And I will focus especially on the symptoms. And you'll see that patients that were categorized as severe had a higher percentage, higher prevalence of shortness of breath compared to less severe patients. And this is most likely the striking difference in between the severe patients and the not severe patient, in the fact that severe patients are, in the majority of cases, have respiratory failure. And we'll see that respiratory failure and the presence of, especially in this case, hypoxic, hypocapnic respiratory failure is one of the main major characteristics that can drive and can guide the management of these patients, and that can drive the outcome too. So, and we see also, and this was kind of particular, that the prevalence of chronic respiratory diseases was very low. We see that COPD patients were around 1% of the population, while cardiovascular diseases were more prevalent. So we talk about hypertension and all the related heart diseases. Another striking feature was that diabetes was quite frequent. And we'll see that these characteristics also drive the outcomes, especially in the severe patients admitted to the ICU. So the majority of patients had radiological findings, which were ground glass opacities, local patchy shadowing, interstitial abnormalities, prevalence was low, and the majority of patients had bilateral patchy shadowing, which is quite kind of a frequent finding also in the patients we treated. And these abnormalities were much lower in frequency than what was seen at the CT scan, because the CT scan was quite a sensitive and also specific tool to use, especially in the emergency department, where for example, we'll see in the next few slides when the swab, the nasopharyngeal swab, is negative, and especially in the pandemic period. So the other characteristics reflect more or less what we also faced: patients with lymphopenia, with altered hepatic function parameters, and also patients that have an increased D-dimer. And we'll see also that D-dimer is a critical feature in patients, especially in critical patients in ICU, but also in patients in general with respiratory failure. And how they treated them, the initial impact with treatment was to give, in the majority of them, antibiotics, oseltamivir, of course empirical, glucocorticoid steroids were given in half of the patients that were severe and half of the patients that were in the ICU or died. And mechanical ventilation was instituted in about 60% of the patients admitted to the ICU that were that later on died. So you see that death in patients that were that had the composite outcome that were, let's say, critical, was around in a fourth, almost in a fourth of patients, which is kind of the mortality we faced also in the hospital and the ICU. So this is our experience, and this is a paper we submitted, is under review right now, and in which we collected more than 400 patients that were coming from 3 different hospitals in Milan, and of 5 different units. And you see that kind of an increased severity of these patients from the compared to the others we saw in the New England. You see that 36 of patients had a PF ratio less than 200, so that can be it can be stratified in a mild, in a moderate severe ARDS. And another striking feature is that 34% of patients had an increased D-dimer, so hypercoagulability was there, and this has been proven as a strong predictor of mortality or adverse outcomes in patients hospitalized with COVID. And also lymphopenia was there. Rarely we saw hyperthrombocytopenia, and so the disseminated intravascular coagulation was rare. On the other side, we all know that COVID patients face a thrombophilic diathesis, so they have a higher risk of PE or deep vein thrombosis. So on the other feature I want to underline is the prevalence of diabetes, which we had was 17%, and especially, and I want to highlight this finding. We have 50% of patients were hospitalized that had a cardiovascular disease, and in particular, 39% of them had hypertension. And so, but despite hypertension and cardiac disease were proven to be independent factor that predicted mortality and ICU admission and intubation in many papers so far. And we'll see that the factor that guided and that inferred the major negative outcome in these patients was respiratory failure, in fact. So let's see what was the initial, what we saw initially in the at the city, which were the radiological findings. This interesting paper came out at the end of February. And the fact that I want to underline with this paper is the CT scans were more sensitive in respect to the PCR assays. But this not only in patients with the same and the same duration of disease, but in general, the CT scan had a sensitivity almost of 100% during the pandemic period. And you see that, for example, in this cohort of more than 1,000 patients, more than 300 patients have had a negative PCR but a positive CT scan with the alterations that we saw earlier in the New England paper. And you see here like a mild case in which the patient develops from left to right ground glass opacities, and that resolve in let's say a couple of weeks, and then again a patient with a positive result of the PCR assay with ground glass opacities, but also a nodule with a reversed halo sign at the lower lobes, and this also resolved. And this is a 34-year-old man. And then we come with to see a 46-year-old man with these alteration, the CT scan seen prevalently after 4 or 5 days of fever, and then the resolution after, let's say, 10, 12 days. But also we have this the example of this 62-year-old man after 2 weeks of fever, the negative PCR assay, and then you see how quickly he developed ground glass opacities, mostly on bilateral, and then the progression with the organizing pneumonia, and then a partial retraction of the consolidation. A retraction that cannot be seen here. This is a more severe case in which you have a bilateral consolidation, ground glass opacities, and without a sign of resolution. And this is a patient with a negative PCR2 at the swab. So the CT scan was really helpful to discriminate a patient that had to be generally stratified in severity and in the first period. We also adopted the chest X-ray, and you'll see that in the few slides that the algorithm in their algorithm is of the triage and then of the management of patients admitted to the general ward on intermediate respiratory care. We used a lot of chest X-ray because they were sensitive too. So this Professor Santuz with collaborators and Professor Nava and Professor Harari published this paper about the management of the non-ICU acute respiratory failure patient with COVID-related pneumonitis or pneumonia. And what I want to underline here is that there was an urge. They were urged to write out a sort of algorithm, and that included the first thing that was able to ensure the maximal protection for doctors, physiotherapists, nurses, and whoever was in contact with these patients and was in charge of the care of this patient. And then to create an epidemiological tool to assess and to triage this patient, to stratify the gravity, and then a diagnostic algorithm to determine which tests should be performed and when. And then we'll see that the chest X-ray has been a very good tool in this case. So they proposed green, yellow, orange, and red stratification based prevalently on the respiratory rate, where the cutoff is 20, and a saturation of 94. And of course, the most critical patients were those with a not responsive, the CPAP or the NIV with high FiO2s and over respiratory with respiratory distress with a P on F ratio less than 200, and that were suggested for the intratracheal intubation or at least an ICU admission. So how it worked in Lombardy, the 112 is our emergency number, and during the pandemic period, the 112 was reflected the phone call to the either to the emergency medical service or to the COVID-19 response team, depending of the type of call. And then the COVID-19 response team was in direct and continuous contact with the hospitals and the public health authorities, and to share all the managing algorithms. And the COVID-19 response team was the team that on which depended either the counseling and the home management of the patients, and depending on the risk of this patient to have contracted the SARS-CoV-2 or have an infection caused by SARS-CoV-2, and depending, of course, on the respiratory symptoms, the risk of contact, of close contacts, and if the patient had the required risk factors, either he or she was asymptomatic, had milder respiratory symptoms, and then he was managed at home and required a SARS-CoV-2 testing at home, or he was dispatched and an ambulance and then hospitalized with severe symptoms. This is the triage algorithm with the yellow area, the red area, in which depending on the response up to the response on the oxygen administration, which was directly managing the emergency department, and then depending on the response of the administration of the reservoir mask of 15 liters per minute, if the saturation was under 94%, CPAP helmet was initiated. In Europe, we used a lot, especially in Italy, we used a lot the helmet because it guaranteed the a low dispersion of the droplets, of the infected droplets, and so it determined a lower exposure risk to the healthcare personnel. So we used a low titration PEEP with a 10 to 12 centimeters of water, and if the patient was not responsive, and then he or she underwent ABG, and then was triaged by the ICU equipe. And then in the paper published in the ERJ, the authors proposed different levels of management depending on the response after, and this is regarding the general ward. So patients were treated in the general COVID ward if they responded at the administration of oxygen. Then the CPAP was continued or administered in the protected areas of the hospital, so the intermediate care respiratory units, with that manage the CPAP or NIV in some cases where the negative pressure rooms were available. And then if the patient after re-evaluation after 2 hours was not responding to CPAP, so he or she had a high respiratory rate, respiratory distress, then he was evaluated also not only by the pulmonologist but also by the ICU physician. This is the algorithm we used mostly in our department to manage the patient on CPAP and to manage the respiratory failure in our intermediate care respiratory ward. Probably the most interesting part, and which differentiate this algorithm from others that were used in that period, was the green part, in which I want to talk about a little bit. And this was not just the putting on a patient on the CPAP helmet, but when to remove the CPAP and to under wet weaning. So at least after 3 days of helmet, and if the FiO2 and the PEEP were stable, and we tried to de-escalate the PEEP to a minimum, and then to assess if the P on F values were stable. If those were stable, we tried a CPAP removal with an FiO2 less than 50% of the venturi mask, and if the patient went well on the venturi mask, and the P on F was above 250, less of course if he or she had chronic respiratory diseases, then after 12 hours reevaluation, the CPAP was definitely removed. Instead, if the patient after CPAP removal or after deteriorating the PEEP showed a worsening of the P on F value or distress after the CPAP helmet removal, the CPAP was restored, and all the process was tried again in the next 24 hours. More or less what happens with the T-tube trial and during endotracheal intubation. So we were, as I said, the coordinating center. There was a phone available to all the intermediate care units, to all the hospital, and the bed requirements and the bed availability was checked continuously in order to dispatch the ambulances and to distribute the patients following the risk charts. So what happened in Italy in the ICU? So we faced quite a little bit tragedy here in Lombardy as for the amount of patients that were admitted to the ICUs, and how and how much was the healthcare burden that hit all the hospitals, and especially in the respiratory intermediate care units and the ICUs. And this paper went out in JAMA, and the first author was Grasselli, and this is in the name of all the ICU network that was formed in Lombardy by Professor Pesenti. And we see which were the characteristics of the patient, more than 1,500 patients that were collected in this observational study. And we see that there is a clear trend that followed the age of the patient that were admitted. And regarding mortality in ICU, we see that the highest mortality, and in particular, more than 30% of mortality regarding patients that were more than 60 years old. And another striking feature was that hypertension, which was one of the major comorbidities that, as we said, was found in these patients, drove the mortality in the ICU. So this was a paper that went out in the beginning of April, and we see what was published lately regarding critical patients in the ICU. This paper was published in a critical care and was an observational study in patients in the ICU in Wuhan, in China. And you'll see that the management and the type of patients that were analyzed were a little bit different, starting from the comorbidities, and especially in the cardiac comorbidities. You see that coronary heart disease and myocardial infarction was very low. And on another striking feature is this mean SOFA, which was quite low too, is around 4. So patients were not that critical, and especially the at least less critical than in the paper of JAMA by Grasselli. And then you see that severe ARDS patients were only a third of them. And I wanted to underline just, and I will go very quickly here, and that only 37 patients underwent invasive mechanical ventilation in the ICU, while 25% of them was managed with a non-invasive ventilation and high flow nasal cannula. And this is the big difference in between the management of the COVID patient outside Italy or outside Europe in the characteristics we see in patients treated with the CPAP helmet that we faced and we used, rather than using other devices, especially because of prevention of healthcare exposure to the droplets. So I will give the talk to Professor Santuz that terminated the meeting. So it was a great pleasure. And please, Professor Santuz.
Morning all together. Sorry for my delay, but I have a meeting with the direction of the hospital related to the new organization of our hospital after the COVID era. And so this is an interesting point also for the respiratory diseases unit, and particularly on the intermediate respiratory. Thank you to Dr. Radovanovic for this. And now I go on of our presentation. And now here you can see our recent results of a study just published and under review. So this slide is very confidentially. Please don't use this one before the publication, we hope. And this slide is very interesting because we identify our patients that come in our division in consideration of the have been divided on the P on F ratio in 4 categories: normal, mild, moderate, and severe. You can see here the level of our patients. And the interesting point is that we identify the different probability in hospital in our patients related to the P on F ratio on oxygenation. And you can see that the line red and blue identify the moderate and severe patients. And the situation is clearly different compared to the mild or normal patients, green and the yellow line. And this difference in survival probability is present after 1-2 days of hospital admission. So this point, this parameter has been at admission in hospital, and after this point, the mortality is clearly different. In the moderate and severe patients, the mortality is about 45–50%. In the other one, about 15% of our patients in hospital mortality. The strong, a very interesting point, because in these patients, and identify the P on F ratio in order to understand the probability during the in-hospital stay. The other point in the patients with COVID, respiratory failure, and COVID-19 is the possibility to undergo tracheostomy. So a very invasive activity. So this is a very recent publication, position paper published in the Lancet very, very recently, 15 days ago, that underline the principal point related to the use of tracheostomy, related to the selection of a patient, the timing, and the use of tracheostomy, the subsequent management of patients. So this paper aimed to provide consensus guidelines and recommendations on the conduct and management of tracheostomy during the COVID-19 pandemic. And this picture is very nice and very pretty, and they identify the time intervention, the invasive and non-invasive intervention could be used. And you can see here that the tracheostomy is not the frequent activity, but normally has been performed or is performed after 14, 20 days of intubation. In the situation in Italy and Lombardy are different, because we know that some ICU unit in some hospital in Lombardy performed the tracheostomy after 4 or 5 days after intubation if the patients have a very dangerous, a very clinical important situation on lung pneumonia, interstitial pneumonia. And so the clinicians, the intensivist doctor understand the possibility to have time in of the patient. And the tracheostomy window of
Professor, we are getting some problem to hear you. Sometimes the voice is very metallic. I don't know what happens. Maybe you can try.
Now is good.
Now is better.
Okay. So this slide identify the tracheostomy window, time for the tracheostomy use, and you can see here that the time is difficult to understand clearly because we have a window for the tracheostomy. In the beginning of the situation or in the past after intubation, in the past time after intubation. But the point that drive this choice are different because are related to the ventilator-associated pneumonia, for example, or the requirement for prone ventilation, or example, the potential risk to healthcare workers, patients and family, and so on. So in the end, this paper underlined some interesting points as the patient selection for tracheostomy. For me, this slide is very important for the clinical practice, for the real life management of these patients, especially in some country where the COVID pandemic is now go on, the timing of tracheostomy, and in the end, the optimal management after tracheostomy, because we have not only the time and the selection for tracheostomy, but we have also the important point related to the management after tracheostomy, related to the cannulation, to the weaning from ventilation, the weaning from the cannulation, the home care teaching, and so on. Here, in the end, some slides related to the therapy. We have used some different therapy with Dr. Radovanovic in our patients. In the beginning of the clinical management of our patients, we work in a hard situation because we don't know a clear therapy that we must use. Unfortunately, the Chinese colleague don't give us clear data, and so we work in the dark situation. So we use different drugs, so we use also different protocol with tocilizumab, with antiviral drugs, and so on. Also in my division, we try to use drugs that normally are used for different situations, and this is the case. In a case control proof of concept compassionate study, we use the platelet inhibition treatment in order to improve hypoxemia in our patients, severe patients. Why? Because critically ill COVID-19 patient experience acute lung failure secondary to parenchymal infiltrate, and this is clear. These infiltrates cause a ventilation perfusion mismatch and intraparenchymal shunt. The associated inflammatory reaction lead to a disproportionate endothelial damage and dysfunction, disruption of regulation of perfusion, and loss of hypoxic vasoconstriction. The consequence hypercoagulability state repeatedly observed in patients with COVID-19 contribute to a fatal deterioration of the ventilation perfusion ratio due to micro and micro thrombosis of the pulmonary vessels. This is clearly identified by our pathologist that demonstrate the presence of a micro and macro thrombosis of the pulmonary vessels, the megakaryocytes activation, and the high level of platelet deposition on endothelial pulmonary vessels. So, related to this point, in order to avoid this severe complication, thrombotic prophylaxis, anticoagulation, and thrombolysis have been suggested, but prospective efficacy and safety data are still lacking. So we use 3 drugs, tirofiban, that is a reversible inhibitor of the glycoprotein GP2B and 3A receptor, the aspirin, and the clopidogrel. Tirofiban has been administered intravenous, and aspirin and clopidogrel by os. We hypothesize that the administration of tirofiban in patients with severe COVID-19 is in association with dual antiplatelet therapy could improve hypoxemia by favoring lung perfusion with a consequent beneficial effect on clinical outcome and respiratory function. Quickly, these are our treated patients, a case control study, 5 patients treated and 5 patients matched controls. Our patients were very severe patients because you can see that the level on PF ratio is very low at baseline, 146. So the medium of severe moderate severe patients, and with a general situation very hard. The dimer very high, 3,000. We have data in literature that demonstrated as a 200 or up level of the dimer is correlated with high mortality, in hospital mortality in patients with COVID-19. So our patients have a mean value of 3,000, very very at-risk patients for in-hospital mortality. So these are the results. The P on F ratio increase after 24 hours and statistically after 48 hours and 7 days after treatment compared to control patients. And the second box are the alveolar arterial grade go down after treatment and go down statistically after 48 hours and after 7 days post-treatment. In my opinion, between three boxes, the more important data is the medium box, the gradient, alveolar arterial gradient, that identify as our therapy don't change the ventilation, but change probably the perfusion of the lung, and so the gradient decrease in terms of a different ratio of the two physiological components of our patient. But the clinical point is clearly reported here. On the right, you can see the control patients, and you can see that the CPAP and MET non-invasive ventilation go without change from baseline to the 3 and 7 days after evaluation. But the situation, on the contrary, completely change in the treated patients, because after 3 days of treatment, our patients improve the clinical situation, and the majority of our patients come from the CPAP non-invasive ventilation to Venturi mask or to room air after 7 days. And we have all the patients that have nasal oxygenation with nasal cannula with a low level of oxygen flow to 1-2 liters per minute. You can see here the patients one, the gray line that go down. These patients go down from CPAP non-invasive ventilation to invasive mechanical ventilation and orotracheal intubation. Why? Because the patients demonstrate to have a septic shock. So not a ventilation or oxygenation problem, but a infectivological problem, a septic shock. So the other trial that has been very interesting in our opinions is these trials registered in the clinicaltrial.gov that has been submitted for consideration in a journal, a scientific journal, clearly. And this study has been a multi-center, Italian multi-center study, prospective observational study to explore the association between exposure to prolonged methylprednisolone and need for ICU referral, intubation or death within 28 days, composite primary endpoint. In patients with severe COVID-19 pneumonia admitted to Italian respiratory high dependence unit. Also in this study, the P on F ratio was 150, 180. So also in this case, all very severe, very hard patients. The secondary outcome in this study were the invasive mechanical ventilation 3 days and reduction in C-reactive protein levels. The data of this study have been very, 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 very interesting, very impressive in the group, in the methylprednisolone group versus case control group. And in the end, the use of doxycycline in these patients. We use doxycycline in our in-hospital patients. First of all, in the beginning of our experience, where we don't know the correct therapy, but also just now we don't correct the best therapy. We know the correct, the more interesting, the supportive therapy with good results. Okay, but in this scenario, at the beginning of a pandemic situation in Lombardy, in Italy, we think also to doxycycline. Why doxycycline in these patients? That we know to be patients with very important respiratory symptom, respiratory impairment, because doxycycline does not interact significantly with any type of adenosine receptor or any of the known phosphodiesterase isoform, except for PDA2A1. And so the lack of effect of doxycycline on adenosine receptor or PDE4 clearly suggests that the action of these drugs are different from theophylline or PDE4 inhibitors, such as roflumilast. Doxycycline can interact with beta-2 airway receptors, eliciting a relaxation of blood vessels and bronchial smooth muscles, so the bronchodilation effect. And in the end, the inhibition of lipopolysaccharide induced inflammatory response in the mouse, lung, and regulate leukocyte migration in vivo and in vitro, effect that suggests an important activity of these drugs on leukocyte diapedesis. It's clear that leukocytes are the first cells implicated in the immune response in this infection, because leukocytes, as Dr. Radovanovic presented before, go down during the infection. And so this identify the important reaction of these cells. So the possibility to modulate the leukocyte could be an important point. And so the three possible effects of the doxycycline related to the bronchodilation, to the inflammatory modulation, and this slide, the possibility to work on the respiratory muscles, particularly on the diaphragm, could be very interesting in this patient with a respiratory distress. So related to these 3 points, we used also doxycycline, intravenous doxycycline in our acute patient. Unfortunately, we don't have a very impressive results. Clearly, a supportive therapy that help us in management of our patients. In the end, we used also doxycycline also at the discharge, in the discharge time of our patients, so at home, with pills 2 times per day, 200 milligram 2 times per day, for a long time, in order to promote all these 3 effects in this patient, because we understand also that the disease don't stop, don't have the end in the discharge time, but come again after the discharge for 1, 2, or 3 months in our patient. Clearly, in more severe patients, come also for 3 months. So the use of some drugs as doxycycline that work on these 3 points, could be very, very important. And last but not last, the safe effect of doxorubicin, also in hospital use and in outside the hospital, because we know, as clearly underlined in this review published 3 years ago on the International Journal of COPD by Professor Clive Page, Cazzola, and Matera, has been clearly underlined the safety of doxorubicin compared to some other methixantine drugs. So we hope that a general and clear situation has been given to us in order to understand and to help all of you in the management of this very hard situation. Fortunately, here in Lombardy now, in Italy, we have a good situation because from 4 weeks, we don't have patients in emergency department with COVID, or better, we have some patients, but with a very mild clinical situation, with immediately discharge, and so the follow-up to home by the generalist, the generalized doctor on outside the hospital. Thank you very much for your attention.
Okay, well done. Thank you, Professor Santuz and Dr. Radovano, for this very interesting presentation. Everything was really very clear. We received many questions during your presentation that we will discuss now, at least just a few of them. I will read the question aloud and leave you enough time to answer them. So here is the first question, Professor. If a patient is taking doxorubicin for COPD and asthma and get infected by COVID-19, should we stop the treatment?
Absolutely no, because the normal therapy is fundamental for the patients, and because as we underline just in the last slides, we identify the important 3 possible effects of doxorubicin. So the modulation of inflammation, the bronchodilation, and the inotropic effect on respiratory muscle. And in the end, the safety profile of these drugs, particularly on cardiovascular situation.
Okay, and here another one. Have you seen COVID damages in any other organs of the body other than the lungs?
Yes. We see the problem in the heart, the myocarditis, for example, in the kidney with a kidney failure, in the also in the cerebral situation with the encephalitis, or also some situation of hepatic failure also. But the more important point is the respiratory failure. Near this situation also some other failure are present, but are composite. In some patients, the heart failure, in some other the kidney failure, or the liver failure, and particularly the thrombosis. The thrombosis is the more important point in these patients.
Okay, here is another one. What do you think about the free movement in Europe for tourism? Could we fear a second wave of infection?
A difficult answer. In my opinion, in our opinion, we think that probably the travel between the different countries in Europe could be performed, but the use of mask is essential. The correct statement in order to take fly or train or some other situation must be essential, fundamental, because the risk is present.
Okay. And another question. We have recently heard about a warning from FDA regarding the psychological side effect after taking Montelukast. What is your advice if we have patient under Montelukast?
But I am not so sure on this point because, first of all, we don't use Montelukast in patients with anamnestic presence of psychological problem, okay, depression, epilepsy, or so on. So normally in Italy, the patient that use Montelukast are patients that don't have central or psychological problem, and we don't see this problem in patients that use Montelukast. Probably, even if because we have a very, very low prevalence of COVID, of asthmatic patients with COVID, a very, very low prevalence. About 1–2% of our patients with COVID are or were asthmatic patients. So I don't know. On the other hand, anti-leukotriene are the drugs that could be used in the modulation of inflammation during a COVID infection. There are some data in ARDS model where the anti-leukotrienes work well in the animal models in order to modulate the inflammation related to the ARDS picture as COVID ARDS. So on the other hand, the anti-leukotriene could work in this situation, but this is only an hypothesis related to the data on ARDS model, so must be demonstrated in the future.
Okay, here is another question. When do you think a vaccine will be available? What is your opinion about that?
We don't work on vaccines, but the point is that probably I think that the vaccines, but I am not immunologist, virologist, or pharmacologist, but I think that the best option could be related to the new next year, 2021, in the first quarter of these new years. If we will have a vaccines before, I am happy.
Okay, here is another one. What is your experience regarding COPD patient and their similar probabilities of being infected by COVID-19 like non-COPD patients? So which is the incidence of the COPD patients about COVID?
Also, the COPD patients in Italy are patients that have been a good management of the disease. Better. We don't have an high incidence of COPD patients with COVID. Why? Probably because the COPD patients stay at home from the beginning of the epidemic situation, and probably also because these patients take correctly the inhalatory therapy or the oral therapy, for example, doxycycline or some other drugs. So use correctly, have a good compliance, a good adherence with the normal therapy. We see the data on the use of inhalatory therapy that during these past 3 months increase so much compared to the before months. So the patients use the drugs, have a high compliance and adherence to the therapy. In our experience, we have a low number of COPD patients in hospital with COVID-19 in our casuistic, in our population, but the situation has been very severe in these patients, because in these patients we have been a high level of mortality and a very severe situation. All the COPD patients have been patients with severe or very severe respiratory failure, with a P on F ratio less than 200. So severe situation.
Okay, here is another general question, especially regarding doxofilling. Can you please give us some words about your personal experience of using doxofilling in non-COVID patients? So generally, few words about your personal experience while treating patients with doxofilling, not affected by COVID, I mean.
Okay. No, we use normally doxofilling in our COPD patient prevalently, also in asthmatic, severe asthmatic, but prevalently in, first of all, in COPD patients. We use doxofilling because we have a preliminary data on use doxofilling as add-on therapy in our COPD patient that demonstrate a clear, important effect on functional lung function parameter, particularly on vital capacity, improvement in vital capacity, reduction in residual volume, so the reduction in lung hyperinflation, and with a good safe. So we use normally this point. And probably these data that are preliminary data compared to the standard care alone could be related to the, in our opinion, to the effect on respiratory muscle, particularly on diaphragm, because in our opinion, the diaphragm work better and promote the more intensive activity of lung function and on breath.
Okay, here is the last question, because some people asked us about what do you think about hydroxychloroquine, so concerning the situation and the fact that there is no evidence about the effectiveness of the drugs.
In the beginning of the infection, we used hydroxychloroquine because it's been the only drugs that normally all the doctor use. So when we don't have option, we use the drugs or the option that all the community, the scientific community use and suggest. In our experience, we agree with the last data, published data on doxofilling, because we don't have a clear effect on our patients. And near the doxofilling, we don't have evidence, hydroxychloroquine, we don't have evidence also with antiviral drugs. We have the clear change with methylprednisolone trial. We have a very important change. So we use after our data methylprednisolone and antiplatelet and antithrombotic therapy in the just and correct dosage, avoid the side effect, and with a monitoring of our patients. So hydroxychloroquine probably now is not a good option. There are some data on doxycycline that with the effect on the leukocyte, modulation of leukocyte, and some molecular mediators released by lymphocyte could work as a modulator on inflammation. We have a case report of 5 patients that identify moderate and mild patient, not severe patient, that identify a good effect of doxycycline at low dosage, 100 milligram per day for 14-15 days, near the use of corticosteroid and low molecular weight heparin at prophylactic dosage for 14-15 days.
Okay, Professor, that's all for such a very interesting webinar. If you have any remaining questions, you can always contact us via ABC website and email address, or via the local Eurodrug offices. We thank you very much for your lecture, Professor, and we would like to thank everyone that joined us for this webinar. We hope this was an informative webinar, and we hope to see you soon again. Be safe and stay healthy. Goodbye. Bye. Thank you again, Professor. Bye. Bye-bye.
Eurodrug. We research for the human needs of tomorrow.